Right. So we're going to talk about cardiac PET. Tomorrow is our first day for cardiac PET at Morris Center. The benefit about that is that we can also do inpatients here. Prior to this, we were unable to do really inpatients for cardiac PET, especially the ones who have any device infection or endocarditis. So what are the current and future applications of cardiac PET? So most of the times, the cardiac PET is used for perfusion. And we use for myocardial perfusion. And also it's considered a gold standard for myocardial viability. And also doing inflammation imaging, which is for myocarditis, vasculitis, sarcoidosis, and same thing with infection imaging. And that is any device infections. And then hybrid imaging, combining CT with PET. Then there are some future applications, which are imaging unstable plaques and using new agents for amyloid imaging, and also new agents for imaging cardiac innervation. And then metabolism imaging, looking for fatty acid metabolism and glucose metabolism. And then immunopet. Immunopet is really interesting, in which you labeled the, say, for transplant vasculopathy patients, you can label rituximab with gallium-68 dotatate, which is going to be picked up by your B cells for allograft vasculopathy. And same thing for treatment of amyloid. You label iodine 124 evusametide with the monoclonal antibodies, and those would go and treat the amyloid or deplete the amyloid fibers from the heart or other organs. So why PET-CT for ischemic heart disease? If we look at the conventional methods, which are stress EKG, stress echo, and nuclear stress tests, about 20 to 30% of the patients have false negative studies. And about 55% patients have false positive. So that really creates a lot of unnecessary CATs in these patients. And also, you don't want to have false negative studies, right? So if we go back a few years, in the mid-90s, when we did our nuclear studies, about 30% of these patients would be positive with ischemia. But now, if you look at the number of studies that are being done, there are only 5% patients who have ischemia on the studies. So we are doing a lot of unnecessary studies. And on top of that, the ones which are red positive, only 45% of those have obstructive coronary artery disease. So if we look at the ischemic cascade, the first thing which really occurs is the perfusion changes, perfusion imbalance. Then you have diastolic dysfunction, then you have systolic dysfunction, then hemodynamic changes, then ECG changes, and then symptoms. So with the flow imbalance, you can diagnose that with PET scan. And then for diastolic dysfunction or for systolic dysfunction, you can diagnose that with stress echo. And then for EKG changes, you can diagnose it as with stress ECG and then your symptoms. So for cardiac PET, how does that work? So for cardiac PET, when the positron collides with the electron, they generate two high energy photons, which are 511 keV. And then you have a PET scanner, which have a row of detectors, and they detect those photons, which are 180 degrees to each other. And that's how the image is formed. Then there are different tracers which are used for PET. Some are produced by cyclotron, or in fact, most are produced by cyclotron. And those are O15 water, ammonia, and fluorpyridaz, which is fluorine 18 labeled. Those are produced by cyclotron. These are perfusion agents. And then for metabolism agents, which are F18, FDG, and also other F18 agents, they are all produced by cyclotron. Or carbon 11, C11, which are labeled for, especially for fatty acid imaging. Those are also produced by cyclotron. The ones which are produced by generator is rubidium, which is used for perfusion imaging. Now, if we look at PET scan, if you look at the count sensitivity, so start on the left side where you see conventional MPI, which are your anger cameras. So your count sensitivity is 0.01%. So that is the counts which are detected by the scanner, which are emitted by the patient. And compare that with your PET, which is all the PETs are now digital PETs, which is about 2%. So it's about 200 times more count sensitivity as compared to the regular anger cameras which we use. Other thing which we look at is looking at the extraction fraction. So if we look at the extraction fraction, the one thing which is the most linear is your O15 water. So that's considered a gold standard for measuring your myocardial blood flow. Then the second best is fluorpyridaz, which is F18 labeled. And then is your ammonia, and then rubidium. And if you look at the Sestamibi or MyoView, which we use for all our stress testing, their extraction fraction is about 48%, significantly lower than PET tracers. If we compare the SPECT scan with the PET scan, so if you look at the count sensitivity, which we already discussed, 0.01% for SPECT and about 2% for PET. Other thing which is important is looking at energy resolution. SPECT tracer are about 140 keV energy resolution. Compare that to the PET tracer, which is 511 keV. So that means higher sensitivity because of better energy resolution. And because of better energy resolution, they have a better spatial resolution. Spatial resolution for the SPECT agents is about 12 millimeter at 8 centimeter distance. It's compared to the PET, which is about 4 millimeter at 8 centimeter distance. The other thing, because of the count sensitivity being so high with PET, the contrast resolution is excellent. And the other thing is myocardial blood flow. Myocardial blood flow you can get with PET, which is the gold standard for measuring myocardial blood flow. And you cannot get that with SPECT imaging. Attenuation correction is part of PET imaging. It's always used. And then the duration of the test. If you look at the duration of the test, your SPECT test takes close to 2 to 3 hours. It depends if you're doing a pharmacologic or you're doing an exercise. And your PET test takes less than 30 minutes for the rest stress perfusion. And we look at the radiation exposure. If you look at the radiation exposure with PET scan, it's about 2 millisieverts, 2 to 3 millisieverts. Right? Living in New Jersey gives you 3.5 millisievert per year radiation. So it's a minimal radiation exposure. Your calcium score gives you about 2 millisieverts. And mammogram gives about 1.5 millisieverts. So it's a minimal radiation exposure for patient. You compare that with the CT, if you're doing prospective or retrospective, again, it's about 5 to 6 millisievert radiation with the CT when you're doing a prospective study. And for cath, diagnostic cath is about 7 to 8 millisieverts. And you guys are not used to it, but for some of us older guys, we used to do dual isotope protocols, thallium and MIB, and that was about 28 millisievert radiation. So if we look at a clinical cardiac PET, rubidium was FDA approved in 1989 and was reimbursed by CMS since 1995. Then ammonia was approved in 2000 and CMS started reimbursing in 2003. FDG 2000 and 2001 CMS approval. The important thing is myocardial flow reserve software. In the past, when I was getting trained, we did everything manually for myocardial flow reserve. We had a couple of PhDs who would spend all day just to measure the flow reserve for these patients. And now it's done in seconds, right? And that's software is approved in 2010. And now we have 4 different softwares with which we can do the flow reserve. In 2019, we got the CMS approval. Flurpiridaz, which we will be using here at Morris Center, got approved in January of 2025. And the reimbursement is from April of 2025. So now if we compare the different modalities, stress testing modalities, right? There was a trial done Pacific, which was head-to-head comparison between CTS, coronary CTS, SPECT, and PET, and they compared all these with invasive FFR. And if we look at the diagnostic accuracy, it was 85% with PET, 74% with coronary CTA, and 77% with SPECT. And when you look at FFR-CT and compare that with PET, again, PET diagnostic accuracy was 86, and for FFR-CT was 70. Other thing with FFR-CT is that about 13% of the patients, you're unable to get FFR-CT because either they have too much calcium or the quality of the study is not that good. You don't have that problem with PET imaging. There are only 2% of the subjects where you fail to get the myocardial flow reserve on the patients. So if we look at the protocols for PET studies, if you look at the top one, which is that's the ammonia protocol. The ammonia half-life is 10 minutes. So the scanning is little longer than an hour. The reason is because you do your rest scan. After the rest scan, you have to wait about 45 to 50 minutes before you do the stress scan. And so the total time is about an hour and a half. But with rubidium scan, because the half-life is short, so you can do the rest, and then after that, you can straight do the stress. So the whole study is done in less than 20 minutes. That's what we used at Somerset Medical Center. We are using rubidium for all our patients. Now the protocol which we will be using from tomorrow over here is flurpiridaz. In flurpiridaz, we are using a lower dose starting with 2.5 to 3 millicuries. We inject that at rest imaging after we have taken our transmission image. And then after that, we wait for 30 minutes for a pharmacologic and 60 minutes for a treadmill exercise test. And then we give 3 times the dose or 2 times the dose for the rest image. That means we're going to use 6 or 6.5 millicuries for our stress image. We can also do a 2-day protocol if we don't want to give more radiation. And in 2-day protocol, we use the same dose. That would be 2.5 to 3 millicurie at rest and 2.5 to 3 millicurie on the second day when the patient comes back for stress. Flurpiridaz is an excellent tracer. Like we discussed earlier, the extraction fraction is about 90% for this tracer. Second thing, which is really good for this tracer, is their positron range. Out of all the perfusion tracers, this has the shortest positron range. And if you have a shorter positron range, you have a better spatial resolution. As you compare this positron range with rubidium, rubidium has an 8.6 millimeter positron range, and this one has 1.03. The only thing is its half-life is longer, so the radiation is little more than rubidium. So the total radiation exposure with flurpiridaz is around 7 millisieverts compare that with rubidium, which was about 3 millisievert, and ammonia is 2 millisieverts. So let's go over the whole study, how we read this study, and what are the different parts in a PET scan. So the first thing what we do is with the PET scan is we look at the reconstruction images to see if everything is reconstructed properly. Second thing we do is we look at a fusion image in which you can see the first one is your emission image, the first row. The second one is your transmission image. And then the third row is your fusion image. Have to make sure that they're properly fused. If they're not properly fused, then you can have a defect, right? If you look at the A image, the top, you can see that it looks like the anterolateral perfusion defect there. But if you look at the fusion image, it's not properly fused, the anterior wall. And when you properly fuse that, the defect goes away. So very important to check if they're properly fused or not. Then after that, we looked at what we call VCACs, which is visually estimated coronary artery calcium score. We had validated that with the regular coronary artery calcium score in a multi-center trial. And so we give VCACs as if it's mild, moderate, severe, or very severe. And mild means if it's less than 100. Moderate is between 100 to 400, and severe is 400 to 1,000, and greater than 1,000 is very severe. And that really helps a lot when we are reading the whole scan. Then after that, you look at your static images, and in the top image, you're seeing short axis starting from apex to base and comparing the stress with rest. And the middle one is your horizontal long axis, and the bottom one is your vertical long axis. So first you get your information whether the patient has any coronary atherosclerosis or not by looking at your calcium score. And then you're looking at the perfusion image to see if there's any perfusion defect there or not. So if you look at your A image over there, you can see the perfusion scan is normal and the calcium score is 0. Compare that to the B, where the perfusion scan is normal, but you have significant calcification, more than 1,000 calcium score there. So that has prognostic significance, even if your perfusion scans are normal, but the calcium score is high. Then after looking at that, we look at the gated images. Gated images are important for PET scan. They're not like SPECT scan. In SPECT scan, after stress, when you cannot really compare the stress gating with the rest gating, because stress gating is done about an hour and a half later. So those are basically, you're comparing two rest gated images. In this, you're looking at the stress gating at the time of stress. So it's important that if your ejection fraction increases by 5% on the stress images, the negative predictive value of having left main disease or severe triple vessel disease is 95%. So very important to look at the ejection fraction on stress compared with rest. If your ejection fraction on stress is equal to rest ejection fraction, then chances are you have a coronary artery disease. You have to look for that. Or if stress is less, then absolutely you have to look carefully and see if you're not missing coronary artery disease. Always after the gating, you also look at your polar maps to see what your sum rest score is, sum stress score is, and sum difference score is. And by that, you will find out what percentage of myocardium is ischemic. So now this is important. So I think Dr. Cormelis can recognize the person in the middle. That's Dr. Paul Cannon. He's the real father of amyloidosis. He was the one who was at Columbia who really started amyloidosis. And then you can see the tall guys, Dr. Lance Gold, he's from Texas, and then Dr. Schwager and Dr. Wolf. These are the 4 guys who were really pioneer of cardiac PET. this was the first study which is on top, a study which was done by Dr. Paul Cannon on a dog at Columbia in 1979. And he showed the time activity curve and showed that you can do quantification of the blood flow in these patients. Then the study on C is a clinical study on a human patient that was done in Germany. And that showed that there was LED defect on that. And the quantification is really important. If you look at the right-sided image, you can see the coronary arteries are greater than 400 microns, right? But you have a mesh of blood vessels which are less than 400 microns, which are your capillaries, your arterioles, and that really supplies most of the blood flow. And measuring the blood flow also helps you diagnose if patient has balanced ischemia or not, and also tells you if patient has diffuse disease or has endothelial dysfunction, and diagnose microvascular disease. The other thing which is important is to see if the patient is a non-responder. You know, what percentage of patients which we do stress on, pharmacologic stress tests, have no response to vasodilators? When we are doing all our SPEC studies, 5% patients have no response to vasodilator. So with this, you can, with the flow reserve, diagnose if the patient is a non-responder. So what I say is, you know, when you're looking at the flow reserve, that's like looking at a video. Before that, when we look at the images, were static images, right? This one you're looking at when the blood, so it's almost like a first pass, but you're looking at the myocardial flow in each region of the myocardium. And you're looking at this time activity curve. You always start the acquisition before the injection is given. Otherwise, you lose your flow reserves. And then what we do is we look at the flow in all 17 segment model at stress, at rest. And then we look at the stress to rest ratio, which gives us the flow reserve. And anytime you have a flow reserve of greater than 1.93, the prognosis is excellent. And when you have a flow reserve of less than 1.5, they have more adverse events. The other thing which is important is that always look at the stress flow. So the different prognostic markers. One is flow reserve, the other one is a stress flow, and the third one is a coronary capacity, coronary flow capacity. All these things are prognostic markers, and we look at different vascular distribution. The one other thing which we do is we always correct it. If your flow reserve at rest is coming up at 1.6, 1.7, right? Because your normal resting flow reserve is between 0.6 to 1.1. When that's higher than that, you correct it for the rest flow with the rate pressure product, and you use your resting heart rate and resting systolic blood pressure times 9,000 and get the rate pressure product. So if we look at this example of a patient on the top, if you look at the static images, okay, it looks completely normal. Your short axis, your horizontal, your vertical long. But when you look at the flow on these, rest flow is normal, but stress flow is decreased, and it's decreased globally. And when you look at your flow reserve in this patient, it's about 1.43, significantly reduced. And when you look at flow difference between stress and left, that's also decreased at 0.44. So this patient has triple vessel disease. So you do a cath and you see the patient has significant triple vessel disease. But if you were not looking at the flow reserve, you're going to call it a normal study. Even with normal static images, if your flow reserve is less than 2, that's a poor prognostic marker. Now, let's look at the couple of examples for the trial which we were part of, fluoropyrimidaz phase 3 trial, which was Aurora trial. And in that, if you look at the top image, which is the SPECT image of sestamib on the left side, right? So if you look at that image, it looks normal, right? But if you look at the same patient getting fluoropyrimidaz after 3 days, you can see the inferior wall has reversible defect. It's a much better sensitivity in diagnosing perfusion defect as compared to SPECT tracers. When you look at the right side, same another patient with the normal, in fact, another patient which looks like there is some defect in this, but you look at it, there's again defect in the inferior wall in that patient. If you look at the quality of the study, on the left side is the gated images of a SPECT scan. On the right side is fluoropyrimidaz. Like I said, fluoropyrimidaz has an excellent spatial resolution. Here you can even see the atrial appendage. You can see atria properly. And so excellent tracer to look for that. Like I discussed earlier, so Dr. Johnson and Dr. Lance Gold looked at 328 patients. So what they do is they check caffeine level on all the patients who come for pharmacologic stress test. And out of the 6,087 total patients, 328 had caffeine levels of greater than 1 milligram per liter. And the 5.4% were caffeine positive. So they did not have response, vasodilator response, because still caffeine was there. So that can give you false negative studies. So with PET, we can also assess whether the patient had a response to vasodilator treatment or not. And that is by looking at the splenic uptake of the radiotracer. So splenic uptake is less in the patients who have a response to vasodilator treatment. Other thing which we do, I would say, every week we do probably 2 patients for cold pressor testing, especially female patients when you want to rule out coronary spasms. So with this test, if you have female patients who are having some atypical chest pain, you want to rule out coronary spasm, you want to rule out microvascular disease. So you do the test in which you do rest scan first, you do a cold pressor, and then you do the stress. You get all the information that first, whether the patient has any perfusion defect, whether the patient has any ischemia, second, whether the patient has microvascular disease, third, if the patient has any coronary spasm. Other thing which is important is, I think, for the transplant patients. So looking at cardiac allograft vasculopathy, this is the best test for that. We had published in 2019, and after that, there have been multiple publications with cardiac allograft vasculopathy, looking at patients not only for diagnosis, but also for prognostication. I think this is an excellent test. So at Columbia, they had switched over from cath. Everyone gets a PET every year. And the only time they would do a PET, the only time they would do a cath, if the PET myocardial blood flow were abnormal, were down. So it's a great test for that. And also we had published that in 2016 for all our renal transplant patients. And that's an excellent test for that too. So in summary, for perfusion, you get your coronary artery calcium score, you get your static images, you get your gated images, you get your flow reserves, and that helps you diagnose if the patient has any microvascular disease or has any balance ischemia. And also it's a prognostic marker. The other thing which we are going to start doing over here also is going to start doing some hybrid imaging, in which you have all your CTs, which are there now, are 64 slice CT with the PET scanner. So you can do your coronary CT, you can do your PET, and you can fuse these images and see if there's any defect and which region is affected, which region is ischemic, so they can decide for intervention that which region to intervene on. For myocardial viability, again, this is a gold standard for myocardial viability. And for tomorrow, we have patients, 3 patients. One is sarcoidosis and 2 are for viability. For viability, we use FDG, fluorodeoxyglucose, and that one goes through GLUT4 transporter protein, which is insulin-dependent protein. So you have the preparation is different in those patients when you're looking for viability, and you want all the FDG to be picked up by the cells which are alive. We always combine it with perfusion. So we do perfusion first. If the perfusion is completely normal, you do not need to do FDG. The perfusion is normal, the region is viable. If the perfusion is abnormal, then you're going to do your FDG scan and look for 3 things. One is match defect, mismatched, or reverse mismatch. Now, if you look at the top image, you can see that LAD has severe defect. Right? When you look at the FDG, the same defect persists. So it's a match defect. So that means this region is not viable. When you look at the bottom image, on that, there's decreased perfusion in the LAD distribution, but there's increased FDG uptake. So this is a mismatch defect. So this is viable. And on this image, it's an ammonia image, it's a discontinuous scale. On that, you can see again that the septum is down, apex is down on the short axis. When you compare that with FDG, here, this area fills in, this area fills in. Same thing over here. Your anterior wall and apex are down, and they fill in with FDG. Same thing over here, it fills in with FDG. So this one is viable in LAD distribution. But when you look at the lateral wall perfusion is normal, inferior wall perfusion is normal, but there is no FDG uptake. So this is called reverse mismatch. Again, this is a stunned myocardium, but viable. So anytime you have reverse mismatch, if the perfusion is normal, that area is viable. Same thing you can see on the polar map, that on the left side is your perfusion map, on the right side is your FDG. Now, if we look at the retrospective data, there's really not that great prospective data for viability, these patients, but for the retrospective data, we looked at 3,088 patients who mean EF was 32%, and if the viability was present, so revascularization was associated with 80% reduction in annual mortality in those patients. If we look at different modalities which are used for viability testing, PET has the highest sensitivity. Like I said, PET is the gold standard for assessment of viability. Now let's talk about myocardial inflammation. So for myocardial inflammation, we really rely on what we call GLUT1 transporter protein. That's a non-insulin dependent transporter protein, which is going to move the FDG into the macrophages. And macrophages has more affinity to pick up FDG as compared to myocardial cells. Again, the preparation is different. Now, tomorrow when the fellows are doing that, so we have put the patient on a no carbohydrate diet for 48 hours. And when the patient comes in, we give them 10 to 50 international units per kg IV heparin. And then after that, we wait for 15 minutes, give FDG injection. Then after the FDG injection, you're going to wait for 90 minutes to 130 minutes to do the scan. Okay. And that's you're looking for inflammation. If you look at over here on the left, there's different patterns you're going to see for inflammation. The left one is normal. The second one, which you see over here, is either poor prep for the that patient did not prepare well, right? And had some carbohydrate, then you can have uptake like that, or in patients with myocarditis. The third one is sarcoidosis, and the fourth one is also sarcoidosis. So when would you consider FDG PET for evaluation of cardiac sarcoidosis? Patients who are under 55 years of age, who present with second or third degree AV block of unknown etiology, unexplained monomorphic VT, or patients with extracardiac sarcoidosis and have abnormal EKG, Holter, or echo in whom cardiac sarcoidosis is suspected, or patients with established cardiac sarcoidosis for evaluation of response to treatment. Just do one case, which was a 40-year-old male who was from Dominican Republic, having some alcohol at a bar, passed out, was brought to the hospital at Columbia University Medical Center. He had a history of, he was a smoker, hypertension, hyperlipidemia, head GERD, was taking Pepcid, lisinopril, metoprolol, and Pravachol. That was his EKG on admission. And he was given amiodarone. And after that, his EKG, you can see his incomplete right bundle branch block, some anterolateral T-wave inversions, and some slightly prolonged QT. His enzymes were high. His was 2.87, 3.08, and 2.48. He underwent diagnostic cath, which showed normal coronaries, and his LV gram showed EF of 45% with mild global hypokinesis. That was his MRI. So you can see right over here, there is late gadolinium enhancement towards the RV side in the mid-septal region. We did a PET scan on this patient. You can look at the perfusion images, the initial one on the top. This mildly decreased perfusion in the septal region. But when you look at the FDG on the short axis in the middle image, you can see that the uptick is right in the middle of the septum. And then when you look at the transaxial images, you can see the septum lights up. He was given at that time solumetrol, then put on prednisone, and also was put on oral amiodarone, and also got an ICD. And then after 12 weeks, he came back after the treatment, and his FDG, you can see that completely disappeared, the uptake which was there on FDG. So for sarcoidosis, there are different patterns which we look at. One is if the perfusion is normal and metabolism is normal, then the patient does not have any active sarcoidosis. For the early disease, you'll have mildly decreased perfusion and increased FDG uptake in the same region, which you can see on your second image, which is 41, 42. You can see that there's mildly decreased perfusion in the anterior wall, and there's FDG uptake in the anterior wall. Then for moderate or severe disease, there'll be severely decreased perfusion and increased FDG uptake. And in a burnt out sarcoid, you're going to see decreased perfusion and no FDG uptake. Then what we do is, this is the only way you can monitor the disease. This is the only way you decide whether you want to stop the treatment, go up on the steroids, add methotrexate, add CellCept. And that we monitor the disease by looking at what we call SUV max, SUV mean in these patients, and target to background ratio. And that helps us decide whether we want to go up or go down on the treatment. Now, there's one patient who had 3.9 on steroid therapy for 2 months. The mean LVSUV went down to 3.2. So the other thing, if some places have PET MRs, those are excellent for looking at sarcoidosis. If you look at the A image, that's the PET image, which shows increased uptake in the anteroseptal and infroseptal and also in the RV free wall. When you look at B image, which shows late gadolinium enhancement in the same region, when you fuse the image, you can see it exactly on the same region. Now, this patient underwent a heart transplant, so his explanted heart showed the same region where there were non-caseating granulomas. Other thing is myocarditis, really important for myocarditis patients. Sometimes they can't get an MRI for whatever reason. You can do cardiac PET on these patients. For infections, device infections, it's an excellent test. We always combine it with WBC tagged images because those have higher specificity but less sensitivity. And these PET FDG images have a higher sensitivity and moderate specificity. Now, this is a patient which is like one of our patients who is admitted right now. This was a patient who was 20-year-old, came in with fever for last 4 days, grew 4 blood cultures, grew MSSA, and they did a TEE and TTE, which did not show anything. They did a CT, which did not show anything. Did a PET. If you look at the middle upper image, you can see there is uptake of FDG at the left main and also at the RCA region right over here in these 2 regions. So they decided to take the patient to the OR. They opened it up, looked at it, but they did not look under the ring and they said there was nothing. Closed the patient. Patient continued to have fever. On 8th day had a CVA. They did the CT scan again and saw that myocardic aneurysm. And on TE saw the abscesses there and then had to take the patient back to the OR. So PET would diagnose infection earlier than echo or CT. So for future applications, so sodium fluoride PET, we had done about 16 patients for coronary, looking at with the coronary CT and sodium fluoride. And, with that, you can really, it would light up the unstable plaque, sodium fluoride. So if you combine the coronary CT with that, you can diagnose unstable plaques with that. In this, you can see that baseline patient has TBR of 2.09, was treated with PCSK9 inhibitor for 18 months. And on the repeat, you can see that the unstable plaque is mostly converted into calcified plaque, and the TBR max has decreased significantly. The other thing which is really important, we are now part of REVEAL trial. So, so this is basically looking at amyloid with iodine 124 evuzametide. We hope to do at least 20 patients by the end of October and that's mostly to diagnose ATTR wild type and also ATTR hereditary type. For AL heart, there's another trial which is done with florbetapen, and that's mostly for AL amyloidosis. So we'll be part of both trials, but REVEAL, we are all ready to start. The other thing which is, I think, very important is fibroblast imaging with PET. So you can image fibrosis. And as you guys know, that fibrosis, I think, is very important because fibrosis begets fibrosis in heart. If you look at the left image over here, where the ATTR wild type patient. These are the patients who get apical sparing. In this, you can see that fibrosis, which you have on the top image right here, all the fibrosis is in the base and base of the anterior wall and the inferior wall. And then when you fuse the images with the CT, exactly this region with apical sparing. With AL, you don't get apical sparing as much as what you get with TTR. And with that, you can see the second example, a lot of fibrosis in the whole heart. And then when we look at chemotherapy cardiotoxicity patient, you can see the fibrosis all around the heart in these patients. So I think it's a great modality, which right now we are in phase 2 trials for this, but hopefully we will get into phase 3. So this is for Dr. Mills, who's our preventive cardiologist. He's a superior doctor. For imagers, we are mediocre doctors. We image the disease. And for our cath colleagues, they treat. All right. So PET is better. Is it time to retire SPECT? So I'll leave that question for you guys and see what you guys think. Any questions? Yes.
Thank you for that amazing overview and talk. As a question that you just asked is salient, why would I as a clinician ever order a SPECT? And I suspect it's a payer issue. Do you have any guidance on who we are likely to be able to get these tests on and who we won't?
I know that's an excellent question. So
if you could repeat that question, there's some people.
right.
Yes.
So the question is that whether it would be easier to get the approvals for PET as compared to SPECT, right? So now it's much easier to get PET approvals than SPECT. The reason is it's not been abused that much yet. So really never had a problem in getting approval for a PET study for perfusion. Yes.
Amazing presentation as always. I know how you can give so many talks and so great knowledge. Really appreciate it. A few questions. Actually I have 6 questions. So on PET, I know there's prognostic data when the EF goes down on the stress through stress images. Now, if the EF drops from, for example, 65 to 60, do you take it seriously? I know if it drops from like 55 to 50 or 45 to 40, what do you mean by the EF is normal and goes down? How do you take that? That's the first question. The second question.
You want me to go answer the first one first? And then, so the first, so there was a nice paper by Sharmila Durabala's group. They looked at the percentage drop in EF in these patients. And whenever they saw that the percentage drop was greater than 5%, right? And or what they call it is ejection fraction reserve, right? So they said if the increase was not greater than 5%, right, that was a prognostic marker. It did not matter if it was 60 or it was 40, the EF to start with. And then the other thing which is important is comparing it with your rest ejection fraction, right? So if the rest ejection fraction is 60 and your stress ejection fraction is 60 or 65 and goes below your rest ejection fraction, that's again a poor prognostic marker in those patients. Right.
Now, what are your thoughts on doing study to PET rest viability study, look for viability, and we get these tests out of it, although the data is plus minus for viability. What are your thoughts on doing stress tests on all of these patients? So stress, rest, viability, because we always focus on viability, but there's underlying ischemia that could be compelling to do invasive treatment. What are your thoughts on that? And do we plan to do that?
That's an excellent question, Yasmin. So the question is, why don't we do rest, stress, and then viability so that we won't miss any ischemia? That's the ideal thing to do. to do rest and stress test and do the viability. The only problem sometimes is that if you cause ischemia after the stress test, then your FDG uptake would be affected. Right? So that's why we say, okay, it's good to do rest and stress, but if you have ischemia, then you cannot rely completely on your FDG uptake. Could be down because of that, or could be increased. So what happens is whenever there is a switch, whenever there's ischemia, your metabolism switches from fatty acid to glucose in the heart, right? So there might be increased uptake of FDG in that region, and that can affect your other regions because you're taking one region which has the maximum uptake and normalizing it to the other regions. So that can affect sometimes your FDG image. But ideally, that's an excellent question to, why don't we do the stress at the same time? So most of the times when you get the viability study ordered, they already have done the cath. They know that there is, either 100% or greater blockage, or if they don't want to do anything, they will order a viability study. So you see, you let them know whether that region is viable or not.
The other question is, we talk about one-stop shop, right? Do one test and get it all. So like we talked about, we can do a coronary CTA, we can, superimpose the PET images, and you have all kind of information, ischemia, et cetera. Now, would we have the capability to do this and analyze in the same software? Because based on my knowledge, currently we don't have the capability of reading on the same software the stress images and the viability. Are we getting software or what's the?
No, so you would have two different software. So basically, the one which we look at for pets is NVIA. NVIA does not have the capability of looking at the CT with that. So I think if we have some software in which we can fuse, that will be excellent, but we'll have to look at it separately.
So I might just add to that. I think this is a beautiful baby that is getting born, but the baby is born with all the amniotic fluids and everything. It's not clean at the moment. So we're going to go through the transition phase. And I want you to be aware of, this is amazing. Like we are at a point where you're right about the one-stop shop. I mean, if you foresee a future where if someone has a chronic stable angina and is not an ACS and you have chest pain, particularly women, and the amount of physiological information that you can get from this is amazing. And for people, and I'm thankful that Connor is here. I think our wish list is going to go increasing. For people who are graduating now or in the fellowship program, you should feel terribly excited because every 1 or 2 or 3 patients, you have a gold standard, and your abstracts and your science is going to be elevated to a completely different level. So what I'm saying is, like, it requires for us to organize ourselves properly from 2 points. Number one is, I think we're going to be constrained by the number of patients that we will be able to do. So I think we'll have to prioritize the people with myocarditis and device infections and other unknown questions. But once we have the capabilities and the maturity with all the softwares and all, we'll have a phased transition. I also believe that we'll have to work very closely with our cath colleagues, because as you would know, that now it is becoming an era. You should not take a patient with uncertainty to a cath lab, right? I mean, yeah, if you have an ACS, you take the cath lab, but if you can plan the procedure well, and you want to do the right thing, you would probably have the CT, maybe PET if viability questions enough, and then do an elective procedure. There's a lot to come, and I'm very excited about the opportunity that this is going to unfold. So let me ask you, Sabi, how many places in New Jersey have the PET at the moment?
So right now, Morristown has it. We started the one at Somerset, but they do not do any metabolism imaging. So we will be doing the metabolism imaging for the whole Robert Wood Johnson Barnabas Health System. These are the only two PET scanners I'm aware of which are here for perfusion studies.
And two leading questions. Number one is, if I understand correctly, the flurpiridaz is a fast, but you can do the testing very quickly, right? Am I understanding?
So flurpiridaz is little longer than rubidium. The reason is because of the half-life is 110 minutes. So we have to wait for pharmacologic 30 minutes in between the two doses. So the whole test lasts about an hour for pharmacologic flurpiridaz. For the exercise, it lasts about 90 minutes because 15 minutes is each scanning time. And then we have to wait about 60 minutes when we exercise the patient.
And with regards, I'm just throwing it out because I want to make sure also we have, if there are health administrators and people. I understand the reimbursement is, the technical reimbursement is very good at the moment. Would you want to cite the numbers?
Right, so the reimbursement is about at least 4 times the spec study. So each spec study, if you get paid about $1,100 or so, for PET, the whole study, you get paid 4,000 something for that. So about 3 to 4 times your spec study. And you can do a lot more of these studies because if you're doing rubidium in 30 minutes, you're done. It's a much better study. You get a lot more information. And I can tell you, especially for the fellows, that by the time you guys are practicing, I think spec won't be there anymore, right? When I started, we used to do magas, stress magas. Everything was stress magas. And you don't even hear about stress magas anymore, right? So now SPECT is going to go away because the PET prices have come down significantly. PET used to be $1.8 million. Now you can get a new PET scanner which Germans are making for cardiac studies for $700,000. So you can just imagine, you pay $300,000 for a SPECT camera, or you put in a PET camera for $700,000 and get a much better test. And also the reimbursement is much better.
What is the work RVU reimbursement for doing all the work?
I don't know.
Because how much time does it take for you to analyze the images?
So the whole study, I would say probably about 15 minutes, not that long.
So I think we can just see how well this could be positioned in our armamentarium of different.
Yes.
And, when you see like the final studies you were showing us, where you really have a conundrum, you can't figure out what's going on, and physiologically it's so much better. But can the health system really, nationally, can you really afford to be doing rubidium spec study, rubidium studies instead of spec, or some other modality for routine patients?
Right. So I think for routine, like your low probability patients or those, you don't need this test, right? So this test is really helpful for mostly your intermediate probability patients where you have to decide whether you want to do something or not. Or if you're doing, say, some other stress testing and you have a test which is not diagnostic, the results, then you do this test, which would give you a lot more information. Again, this test gives you lots of information, tells you about atherosclerosis with calcification, tells you about perfusion, tells you about microvascular disease, tells you about balanced ischemia, tells you about coronary spasm. So if you have a female patient, right, who you are not sure whether she's getting these chest pain because of coronary spasms or not, what other tests we can offer except the cath lab, right? That's a long, I don't even know if we do over here, right? For the cath lab for spasms. So you have a test available for these patients, like you said, for the healthcare. So I think once a lot of people start doing that, I'm sure you remember that when we were doing specs in early 2000, the reimbursement used to be $2,400 to $3,000, right? Now it came down to $1,000 and $1,100. When a lot of people start doing that, payers are going to bring the reimbursement down.
So,
Do you need a cyclotron though?
No, for flurpiridaz,
Right.
this is fluorine label, just like FDG. It's delivered. And the other one for rubidium, you don't need a cyclotron, it's generator produced.
So can I ask a question in the parallel to that? I'm sorry to interrupt. Is there any cost efficacy analysis? For example, when you have an unexplained chest pain and people repeatedly coming to the EDs and that's even bigger cost and they consume a lot of time shuffling between doctors and not having a definitive answer versus you do a definitive test and you get a peace of mind of what is happening in therapies. Is there any cost efficacy analysis?
Absolutely.
Like
So if you look at just the SPECT or echo or exercise EKG, like I showed that 55% of the patient who got the test done had normal coronaries or non-obstructive coronaries, right? So if you're doing a test which is coming back false positive, you're going for a cardiac cath on those patients, that's a lot more cost than doing the PET scan and seeing if the patient has truly coronary disease or not.
Is O15 the only isotope you use for coronary spasm? It's really short half-life, right?
No, so you can use any one of these isotope for coronary spasm. O15 water is not FDA approved in US, but it's available for clinical studies in Europe. O15 water has a short half-life. It's an excellent tracer to quantify the flow, right? Because the half-life is less than 2 minutes. But you can get all these flows, especially fluoropyridase, which has 90% extraction fraction. O15 water has 100% extraction fraction, so it's good. But having 90% extraction fraction with fluoropyridase, you get equally good coronary flow measurement.
So, thank you again. This was really great overview. As you were talking about CAV, I was wondering, it's a denervated heart in these transplant patients. Is there anything to do with microvascular dysfunction to begin with? I know we can look at the flow reserves and I don't think that would change, but if you start looking at microvasculature, is there going to be a difference? Because now the feed is different, autonomic feed is completely different.
That's a very good question. So we always had that question when we were doing even adenosine stress test on these patients or presentin or regadenosin, whether they get the same response like the people who have not had transplant. So their vasodilation response is the same with the testing. But the reason PET is better is because these patients have, develop vasculopathy, which is distally, and then it comes up. So you're going to see the flow reserve much earlier. And even if their scans is completely normal, if the flow reserve is abnormal, those patients are developing early CAV. So those are the ones in which you will go ahead and do the CAT. Now, whether they have some other endothelial dysfunction and other things going on with that, we haven't seen that when we did our study for these patients.
Has Columbia converted to that for CAV analysis?
Everyone PET. All CAV patients get not the first, after transplant, the first year they get more CATs. After that, everyone gets yearly PET. And if the PET is abnormal, then they get a CAT.
About quantitative perfusion, so I know that there are two different CPT codes for PET stress and then quantitative flow, and you get more than $1,000 volume reimbursement. So do we plan to do quantitative perfusion analysis on every single PET stress study, or that would be for specific patients?
Everyone. So we will do everyone quantitative flow and bill for everyone as a quantitative.
But also a lot of info.
Right.
I think Mid-American Heart, I heard they exchanged 16 SPECT cameras for PET cameras.
Yeah.
They switched them all out.
Yeah, Tim Bateman is really completely into PET. And I can tell you that most of the places Columbia has put on 5 now cameras on outpatient areas, and I was there, we had 2 cameras. So everyone is switching to that. That's why I think the fellows, when they start practicing, they'll be doing pets mostly, because the prices are going to come down for the camera. Camera price came down from 1.8 million to 700,000, but it's going to come down further.
Viability studies, can you speak to us about why we would choose PET over MRI and whatnot?
So MRI, when MRI is also considered gold standard, right? But MRI was validated with PET to say, okay, MRI is as good as PET to that. Now, if you have patients who have any device, especially ICDs, in those you're not going to get a good PET image to see if the region is viable or not. If the patient who cannot stay under the tube for MRI for an hour to do this, right? And this PET is not a closed camera that much, so you can get this in much shorter time. So if, like I showed you, the sensitivity for PET is about 85–88% for viability, and the sensitivity for MRI is 78%. So slightly better for viability, but you can do MRI also. But it's, you can select patients, which patients you really want to do PET or MRI.
Last question. So, can we do a part 3 study here? Because, viability is still question mark. So based on our, new, we're starting studies tomorrow here. So maybe we can design a trial and prove it, that, it matters when done properly.
Yeah, sure. Yeah, that would be good.
Where do you come down on that question when the interventional colleague tells you that viability doesn't matter in 2025?
So for that, I think you should come to the debate in the October 18th.
Uh,
On the October 18th, we are having the symposium, and there are going to be live debates on multimodality imaging and CT versus and other modalities and so on and so forth. I think that we are also I think we're scraping the surface. I've learned so much, and I'm going to continue to learn so much. So there's this whole opening of this entity called as non-obstructive coronary artery diseases that is coming into place, where the entire microcirculation and the other artery along with the non-obstructive atherosclerosis and the plaque composition provides a continuum of a disease which has similar presentations, and we call them as ANOCA and MINOCAs and all the chest pain syndromes that are happening in women. We're going to have a huge opportunity to probably do studies.
Absolutely.
In these areas, very open areas for research. Not much is understood, particularly multimodality imaging now, but our ability to understand echo, MR, and PET. We need to design newer questions, retrospective or prospective. I would be very excited with all our research fellows, imaging fellows. Our imaging fellows should probably be excited to get us all together into answering these questions. So we are entering into a very new beginning in all of this area. I'm just excited about this possibilities. All right, with that, I think thank you.